In the third section of our lecture, now we will talk about the management of precocious puberty. In the management, we will talk about the diagnosis, how we diagnose precocious puberty, treatment of precocious puberty, and prognosis of precocious puberty. So diagnosis of true precocious is history of early menarche of mother and sister. History is very important in the diagnosis. If mother and sisters have early onset of puberty or early onset of menarche, that's also there is chances that patient might have early puberty or early menarche. Then pubertal changes occur in orderly sequence. If all the changes of puberty are occurring as the Tanner staging shows, so it means that it's early true precocious puberty. So it's true precocious puberty, or there might be genes or history of precocious puberty or puberty changes occurring in order, like breast and the pubic and axillary hair growth and the growth spurt. Tanner stages are in the sequence. We talked about the Tanner staging in the last section of our lecture. Then no cause could be detected. If no cause is present of a precocious puberty, then it's true precocious or it runs in the family. Investigations are X-ray of the hand and wrist for bone age, skull X-ray, pelvic sonography, CT scan, MRI, serum level of HCG, FSH, LG, then thyroid profile to find out if patient has primary hypothyroidism, serum estradiol, testosterone, and 7-hydroxy levels. Then progesterone and dehydroepiandrosterone electroencephalogram. So all these are the different tests that can be performed to investigate the precocious puberty, the bone age, and pelvic sonogram, CT, MRI, and different hormone levels. This is the bone age picture X-ray of the hand and wrist, 2.5 years, then 8 years, and then 14 years. The diagnosis of true precocious is of premature thelarche, usually the somatic growth pattern not accelerated. So premature thelarche, in premature thelarche there is only the growth of breast tissue, no other signs or features of puberty are present. So somatic growth pattern not accelerated, bone age not advanced, nipple development absent, vaginal smear shows negative estrogen effect. So premature thelarche, only there are presence of growth of the breast tissue. Then premature pubarche, when there is growth of axillary and pubic hair, and ovarian enlargement may not be palpable clinically. Examination under anesthesia or sonography, IVP or CT scan, examination of serum 17-alpha hydroxy, progesterone, DHEAS, and serum testosterone levels should be performed. Then we have premature menarche. Other causes of vaginal bleeding such as foreign body injury has to be excluded. If bleeding is cyclic, diagnosis is confirmed. So if there is premature menarche or beginning of menstrual cycle, it's important that we should rule out any other cause of vaginal bleeding. If that's ruled out and if the bleeding pattern is in regular cyclic manner, then the diagnosis of menarche is made or confirmed. Now, the goals of the treatment: to reduce gonadotropin secretions, to suppress gonadal steroidogenesis or counteract the peripheral action of sex steroids, to decrease the growth rate to normal and slowing the skeletal maturation. So these are the goals, mainly to reduce the gonadotropic hormone secretions and to decrease the growth rate to normal and slowing the skeletal maturation. To protect the girls from sex abuse, the treatment of precocious puberty is cortisone therapy, then the neurosurgery or radiotherapy, and then gonadotropin releasing hormone antagonist therapy. The antagonist therapy will decrease the production of gonadotropin releasing hormone, and then the 80% of the cases are due to increased production of gonadotropin releasing hormone or gonadotropin releasing hormone depending. So the antagonist therapy decrease the production of gonadotropin releasing hormone through receptor blockage. So here the receptors are blocked and this causes decrease of the gonadotropin releasing hormone levels. Then the dose and duration of therapy for precocious puberty. The drug should be used up to age of 11 years and then depending on individual, its individualization is to be done. Which individual is suitable for the treatment or therapy. Drugs usually used are buserelin nasal spray 100 milligram daily, depot form once a month. Then we have medroxyprogesterone acetate 30 milligram daily orally or 100 to 200 milligram intramuscularly weekly. And then cyproterone acetate 70 to 100 milligram per square meter per day orally for 10 days starting from 5th day of cycle. So these are the three therapies and their dosages. So that was all about the diagnosis, investigation and management of precocious puberty. Thank you for watching sqadia.com.